4 judges. They will be marking for each presentation, and I will briefly tell the marking system for all the presentations. Number 1, there is a physical outlook and dressing of the doctor. Time allowed to answer that is 30 seconds. The accuracy of answer, which is positive, carries 1 mark, confidence level 0.5, and language. So I would request the judges to please mark each individual according to this précis, and hand over the précis to the person sitting behind so that they start compiling. So let's start with the topic. The first presenter, Adnan Abdul Majid. He is going to present ocular manifestation of pachydermoperiostosis.
Assalamu alaikum everyone. I am Dr. Adnan Abdul Majid from Sindh Institute of Ophthalmology and Visual Sciences. Today I would like to present a very unique case. There are no financial disclosures. These are the objectives of my talk. A 50-year-old male presented in an outpatient department with a complaint of heaviness in the both eyes since 20 years, and the turning outward of the left lower lid since 3 years. The rest of the history was not significant. The significant history related to my case was he had a joint pains at the knees and the ankle, and his family, his nephew, has a similar complaint. His mother and father were cousins. It was a cousin marriage of the parents. On examination, you can see there was a pachyderma, which is also called the thickening of the skin of the forehead and the scalp. There was a deep forehead furrows, oily skin, excessive sweating on the palm and sole, and the hand and foot were enlarged. There was a clubbing of the finger and the toes. As you can see in this picture, there's a grade 4 parrot beak appearance of the fingers, nails, which is a clubbing. In the foot, there was a similar picture of the clubbing. Also you can appreciate the ankle joint swelling of the both ankles. Ocular findings were, there was a bilateral blepharoptosis with MRD of -2 mm in both eyes. Levator function was poor, and he predominantly used frontalis muscle to open his eyes. Extraocular movements were normal. There was thickened, enlarged, floppy eyelids. Eyelids could easily be pulled away and averted. There was a lid laxity and the left lower lid ectropia. The VA was 2180 in the both eyes, and which was due to the cataract. In this investigation, we have gone for the upper eyelid biopsy, skin biopsy, in which we found that there was a non-specific inflammatory and foreign body giant cell reaction, sebaceous gland hyperplasia, and edema of the cells. And the second investigation, we have gone for the X-rays. Of the X-ray, you can appreciate there is a acroosteolysis. There is the resorptioning of the bones of the distal phalanxes, and there is a periostosis, the subperiosteal new bone formation. Also, you can appreciate a soft tissue swelling of the fingers. And so my diagnosis was, it was a case of a pachydermoperiostosis. The management we have done to this patient was left lower lid wedge resection, which was also the biopsy for the investigation and for the management. And we have planned the LTS for the left eye, and we have referred this patient to the rheumatologist for the further management. Talking about the PDP, pachydermoperiostosis, it is a disease of the skins and the bone, and which also affect the soft tissue. The 3-man triad of this diagnosis is that there's a pachyderma, thickening of the skin, periostosis, and the digital clubbing. These are types. Complete, you find all manifestation incomplete. There's only periostosis without pachyderma, and the form frusty, which is the pachyderma with a minimal periosteal bone involvement. Talking about the epidemiology, the first case was reported in 1868 by Fredericks, and only 204 cases were reported in the world yet. And we reported this case as a 205th case. The male-female ratio was 9:1, and the precise incidence prevalence is still unknown. Talking about the pathogenesis of the disease, it's basically it's an idiopathic condition. We have not yet known the cause, but there are the theories, the neurogenic theories and the humoral theories. Neurogenic theories state that there's a vagal nerve stimulation which is responsible for its manifestation. Talking about the humoral theory, it says there's a prostaglandin E2 mediator which is responsible for causing a fibroblast proliferation and leading to the manifestation of PDP. So the role of prostaglandin E2, it's going on research. It is estimated there is a gene mutation which is responsible for the production of the enzyme which degrade the prostaglandin E2. If it's not degraded, then it accumulates in the body and is responsible for all these manifestations. Manifestation or the clinical feature of the pachyderma skin, it can manifest as a pachyderma, which is a thickening of the skin, hyperhidrosis, cutis vertis gyroid, and decreased facial and pubis hair, and oily skin. Bone, it causes periostosis and acroosteolysis. These are the ocular manifestations, which include the blepharosis, floppy eyelid syndrome, hypertrophy of the lid and the palpebral conjunctiva, mechanical ectropion, meibomian gland dysfunction, tearful instability, and punctate epidural erosion, and ocular surface disease. So take-home message is we have to evaluate and treat patient as a whole. This case was presented to us with the only ocular manifestation, but further we've gone beyond our specialty and evaluate this patient, and then we come up with a very rare disease. So that we have also referred this patient to a rheumatologist, so we are about to save the life of the patient, including treating the eye-related issues. So this was the case report that was presented in the last month in the Pakistan Journal of Ophthalmology. And these are the references of my talk, and thank you very much.
Thank you, Dr. Adnan Abdul Majid, for a very 6 minutes. If you exceed 6 minutes, you'll have -1 mark. So I would request the next presenter, Dr. Nida Junaid, who will be presenting on uncontrolled bleeding after intraocular surgery, blood dyscrasias.
Assalamu alaikum. I'm Dr. Nida Javed from Fauci Foundation Hospital, Rawalpindi, and today I'm going to share with you a rare and interesting case of uncontrolled intraocular bleed during and after surgery, presenting as an initial symptom in a patient with bleeding disorders. This will be sequence of my presentation. Hereditary bleeding disorders, they rarely presents with intraocular or orbital hemorrhage as initial symptoms. Such conditions can be easily overlooked while contemplating ophthalmic surgeries and can give rise to intraoperative and postoperative complications. Awareness of such conditions can improve surgical decisions and outcomes. So this young male of 28 years of age, resident of Gujarat, presented to ER FFH with profuse bleeding from his left eye following left eye surgeries 2 days ago. My patient underwent left retinal detachment surgery at a renowned hospital in Rawalpindi 2 days ago. According to the documents, left scleral buckling procedure was done, and on applying conjunctival sutures, surgeon noticed profuse bleeding from his left eye, which did not stop with any Meyers. So I was packed immediately and injection tranexamic acid was infused. Bleeding did not stop for 2 days, and patient was subsequently referred to Fauci Foundation Hospital, where he was admitted under joint medical and ophthalmology care. Past ocular history of my patient was significant. He was an only-eyed patient with right thigh-sickle eye secondary to blunt trauma in childhood. He had few episodes of epistaxis and hematemesis in early childhood, for which no medical advice was sought. Family history was non-contributory. History of blood transfusion following fall in childhood at 12 years of age was also present. On general physical examination, my patient appeared pale. These were his vital signs. This is the picture of the patient when he presented to us in the ER. As you can see, there is pressure bandage which was soaked in the blood, and bleeding was so profuse that it has trickled down onto his clothes. The pressure bandage was removed. There were matted and swollen eyelids with periorbital hematoma, subconjunctival hemorrhage, and chemosis, so much so that no other ocular details were visible. I was washed with normal saline, and immediate hematology and medical consult was sought. I was packed again. Medical department, in addition to sending clotting profile, also sent factor 7, 8, 9, and von Willebrand factor antigens. The lab results showed decreased APTT time and decreased factor 7 and von Willebrand factor antigen activity. Diagnosis of von Willebrand disease was made. Further management by medical department included transfusion of 8 FFPs, injection transamic acid, and injection humate of 7 vials. They also advised to keep the pressure bandage on for 3 days, and further evaluation of eye under G was planned after 3 days with pre-op infusion of injection humate and 2 FFPs as advised by hematology department. Surgical management by ophthalmology department included lateral canthotomy and cantholysis to relieve the orbital pressure, drainage of subconjunctival blood, and examination under anesthesia revealed clear cornea and positive underglow. This is the picture of the patient from his first weekly follow-up. As you can see that the cornea has cleared, but there is still some subconjunctival hemorrhage and chemosis. This is the picture of the patient from his third monthly follow-up. The periorbital hematoma, subconjunctival hemorrhage, and chemosis has resolved. Visual acuity had returned to 6/6, and interior and posterior segment findings were also within normal limits. The fundus picture of the patient here is showing clear disc and a healthy macula. The bleeding disorders are a group of disorders which interfere with body's clotting mechanisms. There are several types of bleeding disorders, including the most common being hemophilia A, B, C, von Willebrand disease, and vitamin C and K deficiency. Hallmark clinical manifestation of all bleeding disorders include prolonged bleeds, nose bleeds, and bleeding into joints. Ocular complications in these patients can range from subtle subconjunctival hemorrhage to retrobulbar hemorrhage and proptosis, increased intraocular pressure, and decreased visual acuity either because of central retinal artery occlusion, central retinal vein occlusion, optic nerve sheath hemorrhages, and optic nerve compressions. According to a case report published in GMC Ophthalmology Cases 2020, ocular trauma and bleeding comprise only 5% of reported cases of initial presentation of hemophilia. While there are few case reports available on ocular manifestations and hemophilia, data is still largely lacking with regards to von Willebrand disease. Therefore, we conclude that our case study highlights a unique presentation of von Willebrand disease in the form of ocular bleed. In conclusion, inherited bleeding disorders are potentially life-threatening conditions which are underdiagnosed. Ocular or orbital hemorrhage can be a sign of ongoing, more emergent condition, and an incomplete pre-op workup can lead to multitude of intraoperative and postoperative complications. Take-home message: thorough preoperative systemic history and examination, and we can always order relevant tests like clotting profile in case of any suspicion before proceeding to a major surgery. Thank you.
Thank you, Dr. Nida.
It usually affects skin and mucous membranes, but in very few patients, it severely debilitates the ocular surfaces. I, Dr. Taimur Ashraf Khan, shall be briefly discussing stem cell transplant, where miracle transpires. My patient, a 16-year-old female patient, presented to our cornea OPD with complaints of persistent loss of vision in both eyes since the age of 5 years. She developed Stevens-Johnson syndrome at the age of 5 years, with its ocular manifestations rendering her bilaterally blind. The reaction occurred secondary to an unknown systemic medication. On ocular examination, she has visual acuity of perception of light positive in her both eyes, which was worst in her left eye. She had sphere symblephron formation, thick dry keratinization of conjunctiva and cornea, leaving us with no details of the rest of anterior and posterior segment. We performed an ultrasound V-scan which revealed flat retining. She was planned for nasal mucoperiosteal autograft to restore ocular surface niche in her left eye, followed by limbal stem cell allograft. We selected her mother as a limbal stem cell donor on the basis of ABO blood group matching. Her surgery was planned in 2 steps. At the first step, we performed symblepharectomy, exposing superior and inferior third of her left cornea. At this stage, a nasal mucoperiosteal flap was harvested from patient's left middle turbinate under rigid nasal endoscopic guidance. The harvested tissue was sutured to the superior and inferior third of exposed patient's cornea and sclera. Clinically, her eye appears significantly wet and mobile at 4 weeks follow-up as the nasal mucosa regains its function. After 8 weeks, a second surgery was performed. A 5 into 2 millimeter keratolimbus strip containing limbal stem cells were harvested from the superior limbus of the donor. Initial incision was given slightly away from the pelvis of Vogt, working our way up to 1.5 millimeter into clear cornea with the help of a crescent knife. The thin strip was excised using a cornea stitches and was secured over a wet triangular sponge. On the other hand, temporal third of recipient's cornea was deepithelialized. Keratolimbal graft was placed over limbus and secured with continuous sutures. Postoperatively, she was closely followed for the growth of limbal stem cells, which started at 5th postoperative day. It took us 4 minor surgeries before we completely reepithelialized the cornea surface with this new transparent corneal epithelium. On the other hand, postoperatively, she was closely followed for the growth of limbal stem cells. She made a smooth recovery but was troubled with photophobia, which partially relieved by wearing sunglasses, although she gained a navigational vision after this successful transplant, but her quality of life improved dramatically. She is a talented kid, tough and resilient one, who started playing mixed martial arts and archery very few months after a successful graft surgery. When we asked her father for consent to present this case in this conference, he graciously agreed and shared these videos to add in today's presentation. I conclude by saying that this novel technique of using nasal mucosa to restore niche for limbal stem cell transplant has given us promising results in our patient with severe Stevens-Johnson syndrome. Our paper is potentially accepted for publication and is currently under peer review at I Journal of Royal College of Ophthalmology. With this, ladies and gentlemen, I thank you all for your patient listening.
Thank you very much, Dr. Taimur, for a very informative presentation and
with the use of smartphones and outdoor activities. This is the layout of my presentation. Myopia, also commonly known as short-sightedness, is an ocular disorder in which the optical power is stronger than the corresponding axial length. The incidence of myopia is increasing with every passing day. According to a recent research, there is a prediction that in 2050, 50% of the population will develop myopia, out of which 10% will be high myopes. The prevalence and progression is more in urbanized societies. Two most important risk factors are genetics and environmental factors. As we all know that environmental factor is the only modifiable factor, so today I'm going to discuss two most important environmental factors. The objective of my study is to find out the correlation of smartphones and outdoor activities in myopic development and progression. It is a descriptive cross-sectional study that started in February 2022. It is still an ongoing study with a sample size of 100 till now. All myopic children from the age 4 to 16 of either gender were included in my study. All those in whom the best corrected visual acuity could not be achieved to 6/6 were excluded. The data collection was divided into 2 steps. First, all the myopic children coming to the OPD were considered. Secondly, the surveys were conducted in schools in the vicinity of the hospital. In each school, a team of 1 doctor and 2 trained nursing staff were assigned. Students were examined, only myopic children were considered, uncorrected and best corrected visual acuities were checked, and then the students were called for the follow-up at hospital accompanied by a parent or a guardian. At the IOPD, cycloplegic refraction was done for every child who was less than 10 years of age and subjective refraction for elder children. Routine ophthalmic examination was done. That was complete slit lamp examination, fundoscopy, then axial length was checked by A-scan, and then in the end, the height and weight of every child was recorded and BMI was calculated. In the end, the questionnaires were handed over to the parents that had questions about time spent on the outdoor activities and the smartphones. Now, this is the result of my study with a mean age of about 11 years. More male student participation as compared to females, and on average, uncorrected visual acuity was about 0.62. As you can all see, according to the results, more males were myopic as compared to female students. Smartphones have shown a positive and strong correlation with the refractive error, with a significant p-value as shown here in the scatter plot. Outdoor activities have shown a negative correlation with the refractive error. However, the results were not very significant. Another important result concluded from my study was that 64% of the myopic children were underweight, with only 26% normal and 9% overweight on the BMI scale. 62% of the children had positive family history for myopia and 38% had negative. Two important risk factors concluded from my study are the age of the child and axial length, both positively correlated with the refractive error. However, TV hours and indoor activity was not found to be very significant. In 2018, a report was published in UK that showed that 42% of children between 5 to 7 years of age already had a tablet, and 5% had their own mobile phones. This screen time is increasing every year, with an average of about 49 minutes per year, according to the studies. COVID pandemic has definitely further worsened the situation. Sunlight or the UV light exposure results in the release of dopamine and vitamin D, both of which result in halting the myopia, according to the studies. Low UV light and more near work would increase the risk of myopia for about 2.6 times. A meta-analysis was conducted by Sherwin et al. Of 7 cross-sectional studies that showed that 1 hour increase in outdoor activity would reduce the prevalence of myopia by 13%. However, the results were not very significant in my study, and that needs a further bigger sample size, but my study is still an ongoing study. Smartphone usage in the conclusion has shown to be positively correlated with the refractive error. Two important risk factors determined are malnourishment and family history. I thank you all.
Thank you, Dr. Urwa Ghafoor, for a very, very informative presentation. I think all the mothers must be thinking about it. They should stop their smartphones and all the tabs for the children. So the next presenter is Dr. Huzaifa Malik. He's going to present a case of dialk and fungal keratitis.
Assalamu alaikum. Today I'm going to present a case of fungal keratitis, a dialk in case of fungal keratitis. My patient, 30 years old male, presented with a history of trauma to the right eye, after which he developed fungal keratitis leading to formation of corneal ulcer, which later developed into corneal scarring, causing decreased vision in right eye. On examination, his vision in the right eye was hand movement. On slit lamp examination, of the left eye, there was a central corneal scar involving all layers of the cornea, with a central scar of 7 millimeter and a deep corneal scar of 4 millimeter, along with corneal neovascularization. After considering his ocular history, detailed examination, final diagnosis of post-keratitis corneal scarring was made. Treatment option included superficial keratectomy, which could not be performed as a thin layer of stoma would have been left behind, and there were chances of scar extending onto that residual stoma. PKP was not planned as patient was young and we wanted to preserve his endothelium, so the final decision of pre-descent dialk was made. These are the per-op pictures. Here we can see partial thickness definition was done, after which there was needle was inserted and hydrodissection was done, followed by physical peeling of stoma. Here, stoma is being thinned out. Here we can see image of OCT showing thin layer of stoma left behind. Here, after removal of endothelium from donor graft is placed on recipient eye. Sutures are being applied. This picture shows 12 interrupted corneal sutures. This is 6-week post-op picture showing clear cornea. And this here topographic guided slit removal was done, and here we can see after each suture removal, the Myers are becoming regular. I thank you.
Thank you, Dr. Huzaifa Malik. I would request the next presenter, Dr. Umar Irfan Sheen, who's going to present a case of subconjunctival orbital fat prolapse. Umar Irfan Sheen. No, sir, he's not present here. So he's not present here. So we shift to the next presenter. I would request Dr. Munazza Babar. She is going to present efficacy of suprachoroidal versus intravitreal triamcinolone in refractive macular edema, a comparison study.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum to all my respected seniors and fellow colleagues. The topic of my discussion is to compare the efficacy of intravitreal versus suprachoroidal triamcinolone acetonide in refractive macular edema. The sequence of my presentation as shown. The macular edema is the thickening of macula due to disruption of retinal blood barrier, causes leakage from the perifoveal retinal capillaries, accumulation of fluid within the intracellular spaces on optical domain, spectral domain optical coherence tomography. This flowchart explains the pathophysiology of macular edema. As all we know, the Starling's law explains the vasogenic edema, which is controlled by the osmotic and hydrostatic gradient pressure. Whenever this gradient equilibrium is disturbed, it leads to the accumulation of fluid within the tissue. Here are most important causes of the macular edema that includes diabetic retinopathy, macular degenerations, retinal vein occlusions, and inflammatory eye diseases, and some post-surgical causes. The refractory macular edema on optical coherence tomography, central subfield thickness exceeding 250 microns and associated vision loss despite 3 anti-VEGF per month. Insufficiently responds to other therapies after 24 weeks like lasers and anti-VEGFs. The aim of my study is to compare the efficacy of suprachoroidal versus intravitreal triamcinolone acetonide injection in the treatment of refractive macular edema in terms of reduction in the central macular thickness after a period of 3 months. This study was conducted in the Fauji Foundation Hospital. The duration was 9 months. It was a prospective, non-randomized comparative study, and the sampling was done with the non-probability technique. The eyes of 40 eyes was divided into 37 patients divided into 2 groups. The age more than 18 years of either gender with refractive diabetic macular edema secondary to the diabetic retinopathy, wet ARMD or RV, retinal vein occlusion was included, while the phakic eyes previously diagnosed glaucoma and treatment-naive macular edema was excluded. Number of patients, type of injection, dose of injection, and number of injections administered are similar in both groups, while the mode of delivery was in group A is what suprachoroidal space and in group B is what intravitreal. This video explains the procedure, how I have given the suprachoroidal injection in the suprachoroidal space by using the suprachoroidal kit, which was applied on a 1 ml of syringe, taking dose of 0.1 ml. The injection was given in the suprachoroidal space perpendicular to the globe by taking care of all aseptic measures. Post-procedure care, IOP was checked and eye guard was applied. Follow-up was scheduled at 1 week, 1 month, and 3 months, and CMT was recorded on OCT after a period of 3 months. The mean age of group A was 62, while in group B it was 60 years. Number of cases due to the diabetic retinopathy was 32, due to the retinal vein occlusion there are 4, and due to the wet ARMD there were 2, which were equally divided in both groups. This is a tabulated representation of my results. The pre-injection mean CMT was 225 microns in group A and 409 in group B. Post-injection mean CMT was 288 in group A and 253 in group B microns. Maximum reduction was seen in CMT both groups, that was 200 microns in group A and 204 in group B. This is a graphical representation of my results. As you all can see, there was a marked reduction in the CMT was seen after a period of 3 months in both groups. Statistical significant p-test was applied. Suprachoroidal group p-value was 0.00. Intravitreal p group was 0.001. Intergroup comparison show the CMT non-statistical significance difference. The p-value was 0.26. The potential adverse effects that I have observed during my study was raised intraocular pressure was observed in 2 cases of group B, and subconjunctival hemorrhage was observed in 4 cases of group A and 1 group of B. But no other complications like endophthalmitis, vitreous hemorrhage, and retinal detachment were observed. A study concluded in Egypt in 2020 by Zakaria concluded that the suprachoroidal triamcinolone is a safe and effective route for the treatment of diabetic macular edema, which has a comparable effect to intravitreal triamcinolone and may even last longer. Another study conducted by the Abdul Shafi comparing suprachoroidal and intravitreal injection of triamcinolone acetonide in refractive macular edema due to epiretinal membrane. Comparable result yielded in our study. Conclusion, the both suprachoroidal and intravitreal routes of administering triamcinolone are equally effective. Suprachoroidal space is a potential route for the treatment of refractive macular edema and has a good safety profile. Thank you all.
Bismillahirrahmanirrahim. My name is Dr. Khalda Aziz and I'm a second-year resident at PF Hospital, Islamabad. The topic of my presentation is digital eye strain during the COVID-19 pandemic. E-learning was a common mode of studying even before COVID-19 outbreak, and it has been shown to be efficacious mode of learning for the students. And it turns out to have a growing academic scope in favor of the alumni and the students. It also amplifies the staff competence and performance in various educational fields. But following a COVID-19 pandemic, e-learning acquired a substantial rise, and is exercised globally. However, along with the pros, there are a lot of cons as well. Because of this e-learning COVID-19, people are experiencing more digital eye strain these days. A study by Agrawal et al. Concluded that people who used e-learning for more than 6 hours were complaining of eye strain and eye tiredness. Electronic devices like e-readers, laptops, cell phones, and televisions can inflict damage by beaming abrupt energetic waves, and which can infiltrate the ocular layers and cause actinic harm to the neuroepithelial cells, thereby damaging the ocular layers. These symptoms can range from actinic keratosis to macular diseases. The objective was to determine the visual problems faced by the students due to e-learning during the COVID-19 pandemic. So the methodology, it was a descriptive cross-sectional study. The time frame was from July 2020 to October 2020. There were 210 participants. It was a community-based study in Rawalpindi and Islamabad. The inclusion criteria was students who were taking online classes for at least a month and daily hours of at least 1 hour. And the exclusion criteria was students not taking online lectures and those who were unwilling to participate in the studies. So in the results, the age of the students was ranged from 7 to 28 years with a mean age of 21 years. 138, which comprised of 65.7% were undergraduates. Mean period of study was 4.5 months, and mean hours spent daily was 3.9 hours. This was the gender distribution of our students, where there were 17% of the male students and 83% of the female students. We also asked about any pre-existing visual defects. So 90 people had no pre-existing visual defects. 111 students had myopia, 3 students had astigmatism, 3 students had hyperopia, and 3 students had blurred vision. We also asked about the regular use of contact lenses. 45 students did not have had a history of regular use of contact lenses, whereas 165 students did not have any history of regular use of contact lenses. We also asked about the knowledge and the application of the 20-20-20 rule. 20-20-20 rule is actually when we take a break every 20 minutes for a time slot of 20 seconds and look at a distance of 20 feet. Unfortunately, 87% of the students did not know about the 20-20-20 rule. Only 11% of the students knew about 20-20-20 rule, out of which 2.30% did not apply the rules. And we took into account a lot of symptoms, ranging from eye pain, tired eyes, red eyes, sensitivity to light, watering, tearing, headache, neck pain, backache, shoulder pain, blurred near vision, blurred far vision, eye twitching, double vision, decreased vision, etc. And the significant symptoms that we found out were eye pain, tired eyes, and headache. In the females, 28.6% of the females complained of eye pain, 50% of the females complained of tired eyes, and 55.7% of the female students complained of headache. According to the studies, it was revealed that eye wellness associated with display devices have severe consequences on the eye health. But we have to take into account the ecological and communal elements as well, such as socio-economic status, nutritional status, and the general well-being of the students. According to a study by Gan P. et al., it was found out that various factors played a very important role in developing digital eye strain, one of which was the distance from the screen of being less than 20 centimeter, and no breaks taken in between in between using the smartphones or laptops, and also the non-application of 20-20-20 rules and using the gadgets in dark rooms. So in conclusion, e-learning has a considerable adverse effect on the eye health, and it can lead to the digital eye strain. But we have to cope with the digital eye strain, and we have to form a few baseline guidelines. And some of the guidelines which were endorsed globally included, screen brightness adjustment, a gap of less than 20 centimeter, more than 20 centimeter from the gadgets, and use of the 20-20 rule was found to be significantly positive, having a positive effect on the eye health. Thank you.
Thank you very much, Dr. Khalda.
Mahmood from National Medical University, Multan. Let's make it interactive. How many of you have come across drug-induced angle glaucoma? So which drug did you find? Topiramate. So my case study is about that. Okay, so this was the first case that I came across, and I noted it down in the case study. Okay. So let's start with the authors. The authors, first of all, it started with my supervisor, the Dr. Rashid Kumar Rao, and then Dr. Ahmed Hussain, he's also a professor in our department, and myself, Dr. Mamik Mahmood. And let's start with the introduction of the drug. The topiramate is an anticonvulsant drug that is given for the migraine, seizures, and the side effects in eye include angle closure glaucoma, myopia, and macular striae. Okay, the angle closure glaucoma doesn't respond to the conventional treatment of angle closure glaucoma that we usually give for the angle closure glaucoma management. Okay. So let's start with the history and examination. So my patient was 20 years old female. She presented to us with the history of headache for 2 weeks and decreased vision for 1 day. The headache was sudden in onset, mild in intensity, and it was on the temporal side, and it was aggravated by noise, and it was relieved by the medications. The decrease in vision was sudden, painful, and it was associated with vomiting. Vomiting, as we know that the angle closure glaucoma is associated with vomiting due to severe pain. Now she also had the history of taking topiramate for 4 days. That was prescribed by a neurologist. As she actually had the headache, so she actually was referred to a neurologist, and he started topiramate. After 2 days of topiramate, she had blurry vision. And she consulted a peripheral doctor for the blurry vision, and he managed him for the angle closure glaucoma because the angles were severely shallow, and they were severely grade 0 on the gonioscopy. And she received angle closure glaucoma by the treatment by the peripheral doctor, but it didn't improve. So she presented to us. As our hospital is a tertiary care hospital, and patient that don't manage in the periphery, they are automatically referred to us. So we took a thorough history, and the examination at the first presentation was that the visual acuity is 4 by 60 and 2 by 60. Applanation torometry was 30 and 40. The people were fixed, and AC was shallow, extremely shallow, I will say. And the disc was very, I had to made an effort to see the disc, which was 0.4. And how did I manage it? I just started with the IOP monitoring and angle closure with the gonioscopy and Van Herrick's method. And I started the following regime. I gave her the tablet of diclo, which was diclofenac sodium, and which was SOS. And then I started atropine 1%, because studying the mechanism of angle-closure glaucoma, it's actually the effusion of the ciliary body, due to which it closes the angle and causes the features of angle-closure glaucoma. And this was my monitoring. On the right eye, now on the first day. Can you see the mouse? Okay, you can see the mouse. This is the monitoring of the first day at presentation. And then I started atropine, and this is the IOP on the following first, second, and third day. She was discharged on the third day with the IOP of 10 in each eye. So this was all about my case, and it was very interesting to me. That's why I presented to us. Any questions?
We can ask the...
My name is Dr. Nashmia Jalil Malik, and I'm a resident of ophthalmology at PAF Hospital. So my topic today is eyes that cried blood, and it's basically a case of idiopathic hemolacria. So what is hemolacria? It is basically blood in the tears, and it can represent blood from the nasal or passages or the nose, but it's onto the ocular surfaces. The sources of this blood are the ocular adnexa or the lacrimal passages. It can be the conjunctiva, the puncti, the lacrimal sac, or the lacrimal gland. We have various causes of hemolacria, and we've divided them into ocular or systemic. So the ocular causes that lead to hemolacria are first and foremost trauma directly to the ocular adnexa, or conjunctival inflammation, which can include pyogenic granuloma, or vascular lesions of the ocular adnexa. There can be inflammation of the lacrimal gland, and this can be any infection of TB, rhinosporidiosis. There can be malignancies of the lacrimal system. These can be melanoma of the conjunctiva, melanoma of the lacrimal sac, benign papillomas of the sac, and then we move on to the systemic causes of hemolacria. For the systemic causes, we look into endometriosis, nasolacrimal endometriosis that can lead to hemolacria. Then there is epistaxis, which can be retrograde flow of the blood from nasal bleed. There are bleeding disorders, blood dyscrasias, which we discussed in a previous presentation also, that can lead to hemolacria. Then there are vascular disorders, vasculitis, that can lead to hemolacria. We also have functional disorders. Now, in this, there can be psychiatric disorders that can lead to hemolacria, where the patient can harm themselves, or they can instill food coloring into their eyes or even their own blood. Once we've ruled out all of these causes, we can move on to an idiopathic case of hemolacria. My case was a female who was a 28-year-old woman who presented to the OPD with spontaneous blood-filled tears from both her eyes. It was intermittent, sometimes from the right eye, sometimes from the left, but the episodes were multiple, at least twice a week for the last 6 months. These episodes were painless, with no itching, and there was no history of any allergies. However, they were sometimes accompanied by ear or nose bleed. There was no history of infections, no history of allergies or congestion, no history of lumps or tumors, no vascular disorders, no history of bleeding with menstruation. There was no history of trauma to the patient. There were no history of psychiatric disorders or any episode of the patient harming herself. There was no history of anticoagulant use or an exposure to silver nitrate. We did her examination, and on her refraction, we found out that her visual acuity unaided of the right eye was 6.6, while the left was 6.36, which was best corrected to 6.18 partial with a -5 SIL. The K readings were normal. The color vision was normal. However, she was a known case of left anisometropic amblyopia since childhood. Her slit lamp examination was normal. The nexa and the lacrimal passages were normal. Regurgitation test was performed, which turned out to be normal. Her anterior and posterior segment were normal. We retained the patient for in the OPD, and we did probing and syringing to see whether whether we could see blood in her eyes. And this is the video of that patient after probing and syringing, where we can see the blood in her fornix after we performed probing and syringing. We took multiple specialities on board, and we did a gynae consult to rule out endometriosis. We made an ENT consult for her nasal and ear bleed. They just saw clotted blood in the nasal mucosa. Mucosa itself was healthy. The tympanic membrane was healthy. There was just clotted dry blood on the otitis externa. Psychiatric consult was made to rule out any psychiatric causes. The patient was diagnosed as a probable diagnosis of idiopathic hemolacria. And to conclude, I would like to tell you all that hemolacria itself does not have any severe complications. However, it could be a manifestation of an underlying disease. And so we must fully investigate and rule out any ocular or systemic disease before we label a patient having idiopathic hemolacria. To end, I would like to say this quote of Ghalib, where he says, "Ragon mein daudne phirne ke hum nahi qail. Ragon mein daudne phirne ke hum nahi qail. Jab aankh ki se na tapka, to phir lahu kya hai?" Thank you.
Thank you, Dr. Nashmia Jalil. The next presenter is Dr. Wakas. He's going to present complex ptosis with Marcus Gun-Jaw-Wink. Complex ptosis with Marcus Gun-Jaw-Wink. Dr. Wakas.
Bismillahirrahmanirrahim. Assalamu alaikum. I am Dr. Wakas Rahim from Armed Forces Institute of Ophthalmology. Today I shall be presenting complex ptosis with Marcus Gun-Jaw-Wink. Marcus Gun-Jaw-Winking syndrome, also known as Marcus Gun-Jaw synkinesis, was first described by Scottish ophthalmologist Marcus Gun-Jaw in 1883. He described it to be a cranial denervation syndrome characterized by unilateral ptosis and lid retraction associated with mouth opening. Most of the cases are unilateral and there is no gender predilection. The incidence is found to be 2 to 13%. So coming over to the case, my patient, 24-year-old male, resident of a village near Rawalpindi, presented to our oculoplastic department with complaints of drooping of left upper eyelid and its retraction associated with mouth opening. My patient was in usual state of health when at 6 months of age, his mother noticed that his left eye looked smaller than the right one. They took him to multiple ophthalmologists and refused treatments each time. With growing age and increasing social circle, these symptoms had become cumbersome for my patient, affecting his social and professional life. Coming over to the examination, my patient has visual acuity of 6 by 6 in both eyes, and there was visible ptosis of left upper eyelid. Rest of the anterior and posterior segment examination was unremarkable, and my patient had full range extraocular movements in both eyes. Coming over to the ptosis examination, my patient had 4.5 mm margin reflex distance 1 in the right side, which was reduced to 2 mm on the left side. The margin reflex distance 2 was 5 mm on the both sides. My patient had 9.5 mm palpebral fissure height on the right side, and it was 7 mm on the left side. My patient had good levator function and good Bell's phenomena. Here is a video showing the phenomena of Marcus Gun-Jaw-Winking. On the basis of history and ocular examination, a definitive diagnosis was left complex congenital ptosis with Marcus Gun-Jaw-Winking was made. After getting written informed consent, he was planned for left levator muscle excision and frontalis suspension under general anesthesia. Necessary PO workup was done and patient was admitted Monday before surgery. On the day of surgery, general anesthesia was administered, followed by periorbital and conjunctival sac disinfection with 5% pyodine-iodine. This is a video showing the steps. First of all, the incision sites were marked. Surgical blade was used to give the incision. Levator muscle epineuritis was exposed and transected from its insertion. It was then held using a hemostat. This is the hemostat. It was then transected up till width nares ligament. This is the facial aorta sling which was harvested from using Crawford's technique. Using a right syringe, it was passed in suborbicularis plane, which anchored the tarsal plate with the frontalis muscle. Post-operatively, my patient was put on systemic and topical antibiotics with good analgesia. Assessment on the first post-operative day revealed that there was no residual ptosis and no Marcus Ganjow-making phenomena. My patient was discharged happily on the second post-operative day. This is the pre-op and post-op comparison of my patient. Here you can see there is no residual ptosis. This is the pre-op phenomena. And here you can see there is no post-op Marcus Ganjow making. So Marcus Ganjow making is an connection between motor branches of fifth cranial nerve and superior division of third cranial nerve. So electromyographic studies have also proved this hypothesis that this is an aberrant connection between the two muscles. It also presents with few ocular and systemic associations. Ocular associations include superior rectus palsy, anisometropia, amblyopia, Duane retraction syndrome, and morning glory anomaly, whereas systemic associations include cleft lip, cleft palate, and charge syndrome. So I would like to conclude by saying that timely diagnosis and management of congenital ptosis is necessary to achieve better anatomical and functional outcome, and cosmetically acceptable results can be achieved with levator muscle excision and frontalis suspension procedure. These are references that I have used. Thank you all for your patient listening.
Nick, thank you very much, Dr. Saab. So the next presenter is Dr. Ikra. She is going to present selective ophthalmic artery chemotherapy in retinoblastoma. Dr. Ikra.
Bismillahirrahmanirrahim. Assalamu alaikum, everyone. Selective ophthalmic artery chemotherapy is being used nationwide at some centers, and it has recently been started at the Armed Forces Institute of Ophthalmology as well. Retinoblastoma is the commonest primary intraocular malignancy of childhood, and it accounts for about 3% of all childhood cancers. We are all familiar with the international classification of retinoblastoma. This is used as a tool to classify the disease, which helps us in the selection of appropriate management modality. There are various management pathways that can be tailored according to the stage of the disease. We employed the super-selective intra-arterial chemotherapy, and this treatment is particularly useful in management of group D and E diseases. This 3-year-old kid presented to AFIO with bilateral retinoblastoma. As we can see in the slides, the right pupil is almost completely covered with the white reflex, and it's present nasally in the left eye. So right eye was classified as group E, and the left eye was classified in group D. The RETCAM gonioscopy of the right eye showed deposition of retinoblastoma cells in the anterior chamber angle at 6 o'clock. We can see it here. The tumor was completely filling the vitreous cavity, and there was no hope of salvage for the right eye. Therefore, it was planned for enucleation. The focus of salvage was shifted to the left eye. This photograph shows the left eye disease, which was covering almost 50% of the nasal retina, and the vitreous cavity is seen with multiple seedlings. Selective intraarterial chemotherapy was planned, and this has been referred to as chemosurgery. It's a multidisciplinary team approach, which includes an ophthalmologist, a skilled neurointerventional radiologist, pediatric oncologist, and the other ancillary staff.
Canalization of the femoral artery is achieved under ultrasound guidance. Here we can see the catheter being inserted in the femoral artery. This video shows the microcatheter being advanced through the aorta, through the internal carotid, common carotid, to the internal carotid artery. And then another angiogram is taken to confirm the placement, angioanatomy, and to see the choroidal blush. This C-shaped ring is seen as the choroidal blush, and it indicates that the flow to the ophthalmic artery is achieved. The drugs are then injected in a pulsatile way. These are the RETCAM images showing comparison between the pre and the post first session of the intraarterial chemotherapy. It can be clearly appreciated here that the tumor has regressed. So in the follow-up visit, after 2 weeks, this patient developed a vitreous hemorrhage. Second session of chemotherapy was done, and here we can see that the tumor has regressed further, and it is becoming relatively avascular. Now, at the third session of the chemotherapy, it was found that the ostium of the ophthalmic artery was narrowed. Hence, further sessions of chemotherapy were abandoned, and patient was advised systemic chemotherapy. Since the tumor regression was accompanied by tumor necrosis, this patient developed a rhegmatogenous retinal detachment. This was repaired with the radial scleral buckling, and there was a lot of subretinal fluid present, and it was not drained because we did not want to spill the retinoblastoma cells into the rest of the orbit and adnexa. Radial scleral buckling was done, and it failed because of the subretinal fluid. Pars plana vitrectomy with silicone oil was then done, and 360-degree scleral buckling was performed. In this, we can see this is the scleral buckle, and over here the tumor has regressed and it's focally consolidated. At present, the post-op retina of this patient remains flat under silicone oil, and her best corrected vision is 6/15 in the left eye, despite undergoing multiple surgeries. I would like to conclude by the take-home message that the availability of effective chemotherapeutic agents has shifted the focus of management from saving the life to globe and vision salvage. Chemotherapy is gaining popularity, but there should be no hesitation in sacrificing the globe if we want to prevent the systemic mets. Thank you.
Thank you very much, Dr. Ikra. The next presenter is Dr. Umair. He's going to present unusual case of intraorbital foreign body. Dr. Umair.
Bismillahirrahmanirrahim. I am Dr. Umair, and I shall be presenting a case of an unusual presentation of an intraorbital foreign body. This is the case presentation. My patient, 6-year-old male, a resident of Islamabad, presented to our OPD on 9 January with the complaints of pain, redness, and difficulty in opening the right eye for the last 12 days. My patient was in his usual state of health until 12 days back when he developed pain and redness in his right eye. Pain was severe, localized, and was aggravated by eye movements and was also associated with limited eye movements. Parent took him to an ophthalmologist who diagnosed it as a case of conjunctivitis and sent him back home. But despite treatment, his pain and redness did not improve. They went to multiple ophthalmologists. One of them performed X-ray on the suspicion of foreign body, and patient was referred to our hospital. At our hospital, patient was re-evaluated, and on history taking, he stated that he was playing with his friend in his class when they started to fight with each other. During that, patient threw pencil on the floor. That pencil bounced back, hit his face, and he was unable to find that pencil again. Here on ocular examination, you can see mild periorbital swelling, ptosis of the right upper eyelid, and limitations of the extraocular movements in all gazes. So a differential diagnosis of intraorbital foreign body, blunt trauma with orbital wall fracture, and orbital cellulitis was made. Patient was admitted for necessary investigation. His ultrasound B scan was done, which revealed a flat retina and an intact globe. His CT scan orbit and brain was done, which revealed a linear tubular foreign body with an outer hypodense attenuation and an inner hyperdense attenuation. It was seen extending from the medial canthus between the medial rectus muscle and in the inferior rectus muscle. And it was seen extending from the superior part of the superior orbital fissure right up till the lateral margin of the cavernous sinus. His CT angiography brain was done in order to rule out the involvement of internal carotid artery. It was unremarkable. This animation has been made to show you the location of the foreign body, which is seen extending between the globe and the medial orbital wall, between the medial rectus muscle and the inferior rectus muscle. So, a provisional diagnosis of right intraorbital and intracranial foreign body with third and sixth cranial nerve palsy was made. Parents were consulted regarding the management of disease, treatment option, expected outcome. Surgical removal of the foreign body under general anesthesia was planned. Patient was draped, right medial orbitotomy was done, and incision was extended to the inferior fornix. Deep blunt dissection was done, and tip of the foreign body was identified. Foreign body was removed in toto. It was a lead pencil measuring more than 6.5 centimeter in length. Cavity was placed with fibrillar hemostat, and hemostasis was achieved. Post-operatively, his CT scan was done, which revealed a heterogeneous soft tissue density, which was consistent with the fibrillar hemostat that was placed per op. Patient was monitored for optic nerve function and retroorbital hemorrhage and was discharged on second post-op day. Post-operatively, his third nerve palsy improved over the period of time, but his sixth nerve palsy did not improve. After 6 months of initial surgery, patient had a squint of right eye, right esotropia, for which right medial rectus recession was done. At present, his eyes are straight with a visual acuity of 6/6 in his both eyes. Ocular trauma is defined as injury to the eye and surrounding structure. It is a major cause of preventable monocular blindness worldwide. Ocular trauma and resultant loss of vision lead to psychological, economical, and professional crippling of the patient. Keeping in view of the above, WHO has enlisted it as a public health issue. In the end, I conclude by saying that immediate treatment is directed at preventing further injury or vision loss, and parents should be encouraged to exhibit friendly behavior toward their children in order to nullify any communication barrier. These are some of the references that I have used. I thank you all for your patience listening.
Thank you, Dr. Umair, for a very precise, concise presentation. Now, the second last presentation.
The angle clear glaucoma. Well, I'm not going to ask any questions. Just a few comments. Whenever you see a patient with bilateral acute angle clear glaucoma, that's because of a secondary cause until proved otherwise. That's what you have to remember. The second point is that although in this patient the history was very obvious, so you knew that you had to dilate the pupils, right? But there will be situations in your career when you are dealing with an angle closure situation and you're not sure whether you should constrict the pupil or you should dilate the pupil. This will happen, right? So under such a situation, the logical sequence of events is that you bring down the pressure by medical means and do a YAG-PI, right? Do a YAG-PI in both eyes and then dilate the pupil so that you can get rid of the angle closure component. And number 3 point is that remember that the objective of a YAG-PI is to prevent a subsequent angle closure attack. That's the main objective. The lowering of the pressure is a secondary event. Okay?
Thank you, sir. The result will be compiled in 2 to 3 minutes. I would request the judges, sir, आप कुछ input देना चाहें presentations और उसके बारे में तो वो ज़रा उनको guide करें.
Thank you so much. It has been a marvelous session of the presentation with the juniors, and really I was amazed to see some very, very uncommon cases in the presentation and very, very relevant day-to-day situation related researches. I congratulate you, all of you. I personally feel when I was marking, I was feeling that it will be a very tough competition between the presenters to fight for the first 3 positions. I rated and marked and gave and then forget, and that I was relaxed. But the asal now tension lies on the Shehzad, how they compile that and how they bring the final result. And once the result comes, we will again be in front of you. And Shehzad will announce the result?
Sir.
Yes, please.
So, Shehzad, before you start the number games, let me congratulate you, General Mazhar, and then specifically it was, we are thinking of medical education, तो हम कहते थे कि ये scholarly pursuit और बहुत पढ़े लिखे लोगों का elite सा club बन गया, तो let us take it down to where it belongs, to the postgraduates and the undergraduates. So having discussed it with Shehzad, and I'm very glad कि आपने उसको implement किया और फिर ना सिर्फ implement किया बल्कि ownership दी आप लोगों को. So a round of applause for Shehzad actually.
Sir, I think it's an honor for OSP Federal, and I'm sure all the participants here, कि people of your caliber and Professor Mia Shafiq, आप लोगों ने इस चीज़ के लिए time निकाला till the end. We are really grateful to you, sir. Thank you. So, announcing the results, first we'll announce the third position. The third position, अच्छा थोड़ा सा ये 4 judges थे, चारों की markings थी और markings gross नहीं है, आप लोगों ने वो देख लिया सारा, 1-1, 2-2 marks में, तो इसमें transparency बहुत fair हो जाती है. Third position is shared by 2 participants, Dr. Ikra and Dr. Munazza Babar. ये उधर दे दो बेटा. ये एक्चुअल तो ये है ना सर इसके अंदर. ये उनको देना सर. एक्चुअल पैसा इसके अंदर है. सर दोनों का शेयर है ना सर. वो अब उनकी मर्जी है, वो किस तरह आपस में फैसला करते हैं. So, thank you. Congratulations. The second best paper of the conference is by Dr. Umair. Yes, second. बेटे ये भी ले लो, मेन चीज आप छोड़ दो. ये ले, ये पहले ही दे दो, पहले ही दे दो. And ladies and gentlemen, the best paper of OSP Federal Conference Bhurban 2022 goes to Dr. Wakas. Sir, I thank the judges again, sir. बहुत शुक्रिया. Thank you so much, sir. Thank you, sir.